Hey guys, sorry. I was chatting away and didn't realize that the thing cut off on me. So I got almost through this and then realized it. Okay, so um, continuing with hypervolemia as a result of increased water and sodium retention can lead to increased intravascular fluid volume and interstitial fluid or edema. Some signs and symptoms of hypervolemia are weight gain, ascites, edema, increased urinary output, cardiac signs and symptoms like hypertension, tachycardia, JVD, development of the S3 heart sound. Remembering from health assessment that the S3 is present because of the large amount of blood volume that are entering the ventricles. So that can cause that extra heart tone. And then JVD develops as blood backs up in the right side of the heart. So we will see that JVD. Some respiratory symptoms develop as fluid leaks from the pulmonary capillaries into the alveoli because of the increased circulating blood volume and the inability of the left side of the heart to pump the blood volume forward to then perfuse the body. So because of that, blood will then back up into the lungs, and you will see them have respiratory symptoms like coughing, tachypnea. They will have adventitious breath sounds like crackles, wheezing, or orthopnea, and decreased oxygen saturation. Sorry, wrong slide. Um, so medical management aimed at prevention, correcting, managing, cause, and treating signs and symptoms. Limit daily intake of fluid and sodium, monitoring their weight. We'll probably typically weigh them daily. Um, Typically, if they gain 1 to 2 pounds in a day or 3 to 5 pounds in a week, that is an indicator that we are in hypervolemia. We will then use diuretics, and if diuretics do not work for getting rid of the fluid volume, then we can put the patients on temporary renal dialysis, which will help the kidneys get rid of the extra fluid if they can't, if their body is just can't work, keep up with, their kidneys can't keep up with the amount of fluid within their body. So some complications are worsening heart failure with pulmonary edema, um, which is potentially life-threatening condition due to progressive hypoxia that develops as the oxygen exchange is compromised because of the fluid in the alveoli. Emergent interventions for pulmonary edema include oxygen therapy, diuretics, morphine, because that's going to lower your respiratory rate so you're not having to work as hard, and then vasodilators to help hopefully open up the airway, open up the capillaries, um, uh, and help to prevent, your ability and help you breathe a little bit better. All right. Fluid and electrolytes. So some functions of electrolytes. They distribute body water between fluid compartments. They are a regulate acid base balance. They maintain body fluid volume and osmolality, and they promote neuromuscular um, capability. All right, so sodium is what we're going to talk about first. The normal sodium level is 135 to 145 milliequivalents per liter. It is a cation, contributes to serum osmolality. The function is primary regulator of volume, osmolality, and distribution of extracellular fluid. It will help maintain neuromuscular activity. It maintains blood volume. It is the most plentiful electrolyte in the extracellular fluid. It helps transmit neuromuscular impulses, and it combines with chloride and sodium bicarb, which is HCO3, to regulate acid-base balance. So that is the primary task of sodium. Sodium levels are controlled by thirst, the antidiuretic hormone, and the renin-angiotensin-aldosterone system. So if sodium levels are with elevated sodium levels, the release of the antidiuretic hormone is seen, which then will stimulate the thirst mechanism within the body. So hopefully your body will say, I'm drink more water. Your sodium is getting a little bit elevated, and hopefully by you drinking that will help to decrease that. So typically in most countries, the normal intake of sodium, this is pretty sad, is 500 milligrams a day. But in the United States, it is about 6 to 15 grams a day. So we are putting a lot. That's why a lot of people in this country have kidney issues, because we're putting a lot of kidneys excrete the sodium. So we're putting a lot of, hardship on the kidneys. Some sources of this include table salt, seafood, cheese, and processed foods. So again, it's the most abundant electrolyte and extracellular fluid. It helps maintain osmotic pressure and acid-base balance with the sodium bicarb and the chloride. Again, the aldosterone assists in regulating serum balance, and it's affected by food intake. All right, so first we're going to talk about hyponatremia. Usually it's less than 135 milliequivalents per liter. If it gets to be critical, it's less than 125 milliequivalents per liter. Managed with sodium-containing fluid and food. Some signs and symptoms are headache, lethargy, confusion, seizures, nausea, vomiting, and coma. Treatment, fluid restrictions, and severe neurological symptoms. They can give 3% normal saline and oral sodium supplements, like you can give sodium bicarb sometimes too, and loop diuretics. So the reason they give the loop diuretics for these patients is it will gradually increase the serum sodium concentration. So that's why they give those for, especially for heart failure associated hyponatremia. So if somebody is in heart failure, they will give loop diuretics if they are having low low sodium. So, and hypovolemic, we're going to talk about hypovolemic hyponatremia first. With this, there's typically a decrease in the total body sodium and water in the extracellular fluid as either a result of renal or like some kind of renal loss. The use of loop and thiazide diuretics is a cause of renal water loss, with thiazide diuretics being more likely to cause hyponatremia through renal loss of sodium. So, sodium may be lost secondary to diarrhea, vomiting, hyperglycemia, and glycosuria, and perspiration. Some clinical manifestations of hypovolemic hyponatremia include weight loss, orthostatic hypotension, tachycardia, abdominal cramping, and polydipsia, or the increased thirst. Because that mechanism, again, your hypovolemic hyponatremia, your body, the antidiuretic hormone is activated, and thus it says, okay, the thirst, and it will hopefully increase your thirst. Then we have euvolemic hyponatremia, which occurs when there is an increase in total body water with no evidence of edema or hypovolemia. This can be seen in patients with the syndrome of inappropriate diuretic hormone or other endocrine disorders like hypothyroidism, or some kind of adrenal insufficiency. Because of these, they impair water excretion. So some other things, causes are, some medications can also cause this to occur. And then we have hypervolemic hyponatremia, which causes an increase in the extracellular fluid, secondary to increases in total body water. It is seen in patients with heart failure, cirrhosis, and nephrotic syndrome. Acute kidney injuries. So with these, we're going to try to sodium and water restrictions and treat underlying cause for these patients. All right, so we have hypernatremia, where the sodium levels are greater than 145. These are managed with fluid replacement at a moderate rate. Signs and symptoms include disorientation, hallucinations, agitation, restlessness, neuromuscular irritability, confusion, seizures, lethargy, tachycardia, dry mucous membranes, skin flushed, agitation. Some treatment Fluid replacement with hypotonic fluids like half normal saline or D5W, and we are going to treat the underlying cause. If sodium levels get above 152 milliequivalents per liter, patients can have the seizure, stupor, coma, and death. So we need to be mindful of that. Here are some causes of elevated serum sodium. Medications, some meals, especially increasing too much sodium intake, osmotic diuretics, diabetes insipidus, excessive water loss, and low water intake. So now we're going to talk about potassium. Normal potassium level is 3.5 to 5.0 milliequivalents per liter. This is the major cation in intracellular fluid. This helps to maintain intracellular fluid osmolality. It's needed for skeletal, cardiac, smooth muscle function, neuromuscular and cardiac functioning. It helps to maintain the resting membrane potential of nerve and muscle cells. Either a deficit or excess adversely affects neuromuscular and cardiac function. It's regulated by the kidneys. Typically, they eliminate potassium very efficiently, but it does not conserve it well, so it can spill out. It can urinate a lot. Renal failure can lead to serious elevations of potassium. So if your kidneys aren't able to put out that extra potassium, then they can have serious elevations. It is the most important electrolyte to monitor, especially after surgery or any, especially cardiac patients, EKG changes, things like that it's important to monitor. Some sources of food that can be high in potassium: meats, whole grains, green leafy vegetables, potatoes, bananas, oranges, apricots. So should be ingested daily to keep that in track. Again, it's the intracellular cation. It has the role in cellular depolarization and repolarization, which is an important function of the cardiac function of the heart. You need your cells to depolarize to repolarize, which causes that contraction of the heart muscle that you want it to have, that is equal with the atria and ventricles pumping, so that you have enough blood to then pump out of your heart and circulate and to perfuse your body. So it is very important, cellular depolarization and repolarization. So again, there's some things that potassium is essential for. All right, so if we're looking at hypokalemia, that's typically under 3.5. Critical value, I say we're going to start getting a little worried, under 2.5. Typically under 3, they're going to be like, okay, we need to treat this. So again, below 3.5, it's going to affect the entire body. And if it's not corrected, it can cause cardiac and respiratory arrest. It affects the transmission of nerve impulses with the contractility of smooth skeletal and cardiac muscle. Losing too much potassium through the kidneys with inadequate intake, like because of anorexia, alcohol, because anorexia, obviously for obvious reasons, they're not taking in enough. Alcoholics, typically if they're drinking more alcohol, they're not ingesting enough food intake or vitamins, minerals, electrolytes that they need. And then excessive output. So if you have somebody who has GI loss, like from vomiting, diarrhea, or medications like diuretics or things like that, it can cause that to have you can lose more potassium. All right, so some signs and symptoms of hypokalemia include cardiac, pulmonary, neuromuscular, and GI symptoms. Again, cardiac arrhythmias, pulmonary issues, the neuromuscular rigidity, and you can have nausea, vomiting, diarrhea, and things like that. Can have weakness, lethargy, hyporeflexia. So you're going to have the hyporeflexes within your muscles, abdominal cramping, EKG changes. Severe hypokalemia can lead to cardiac respiratory arrest can occur. So we need to supplement them with potassium replacement. If severe hypokalemia, administration of potassium both orally can be required. Due to potential for cardiac dysrhythmias, patients with hypokalemia should be placed on cardiac monitoring. Please know if you guys are going to give anything IV with potassium, it burns a lot going into the vein. This is a medication where you cannot do an IV push. It can be caustic to veins. It can cause necrosis in veins. So typically you don't want to have it in just like Phenergan, you don't want to have it given in like a vein, a small vein or a vein in your hand. Typically a larger vein will be better for a patient when you're administering this, and you never ever give it IV push. You can kill a patient doing that. So those are some big no-nos for potassium. All right, so with hyperkalemia, serum potassium levels greater than 5.0, critical values are greater than 7, can occur due to acute or chronic renal failure, some medications, excessive intake of foods high in potassium, or because of shift of intracellular potassium into the extracellular space. Constipation can lead to hyperkalemia, especially for patients with chronic renal failure. If patient has constipation, they're greatest risk for developing hyperkalemia. So just put that in your back pocket. All right, some signs and symptoms. Generalized fatigue, muscle cramps, heart palpitations, paresthesia, weakness. Patients at high risk of cardiac arrest. Patients can develop bradycardia, sinus arrest, heart blocks, ventricular dysrhythmias. Because of these cardiac rhythm abnormalities, they can develop symptomatic hypotension. So what do we do? Treatments. Calcium gluconate. If there are EKG changes are present, calcium will not decrease potassium, but it will reverse EKG changes. And then it will decrease risk for ventricular dysrhythmias. It is very short-lived when you give IV calcium gluconate. It will only last about 30 to 60 minutes. But if a patient is high, that is a preventative, so we don't let them go into cardiac arrest. Insulin and dextrose can be given, and that can help to decrease it as well. Sodium bicarbonate can be given to help to decrease the potassium levels. Loop diuretics, like with furosemide or Bumex, and K-exolate, because if you have holding on to potassium in your poop because you're constipated, we give K-exolate for you to poop it out. So it's another way for you to get rid of the high potassium levels is through that. So going back to dextrose, if we give IV administration of 25 to 40 grams of 50% dextrose with 10 units of short-acting insulin, it will promote the movement of extracellular potassium into the cells. Use of regular insulin will shift glucose into the cell, and potassium follows the glucose. So it can be, it take several hours to accomplish, but it can be done by giving that insulin and dextrose combined to help to prevent that. If a patient is in metabolic acidosis, correction of the underlying causes will result in shifting the potassium back into the cell. So we can give sodium bicarbonate may be required to help with that shift, because sodium bicarbonate is something found in the extracellular fluid, so it will help with that shift. And then obviously with loop diuretics, it will help you to pee off the extra potassium. All right, so you'll learn more about this in level 4 with cardiac issues. But if you have a patient, so this is what a normal EKG rhythm strip is. You have something called a P wave, a QRS, a rounded T wave, and a little U wave. It's not always present, but it can be present. If you have hypokalemia, you can have a prolonged PR interval. So this thing normally you see is here, like this little thing right here. It can be prolonged, so a little bit longer. This P wave can be slightly peaked, so you can see it's not as round. It's kind of higher, like a tip. You can have ST depression. This is your ST T wave. So ST, it's depressed, it's not on this isosymmetric line, it's got a depression. You can have a shallow T wave where it's not as high and rounded, it's kind of lower, and then you can have a prominent U wave. So sometimes U waves aren't on every EKG, but if you have hypokalemia, it can be a little bit more prominent. And then if you have hyperkalemia, you can have this wide flat P wave. Again, a prolonged PR interval. It's going to be here. Decreased R wave amplitude. So usually, your R wave is really high and it's peaked really high. This one is not as high. And this tall peaked T wave. That is a very good indicator. Oh, also a widened QRS. So usually your QRSs are kind of skinny right here. It's going to be very wide. And then you can have peak tall T waves. So those are all kind of all indicators that you have hyperkalemia, hypokalemia. Those are differences that you can see. All right, so calcium. Calcium, the normal serum level is 8.2 to 10.2 milligrams per deciliter. It's mostly found in skeletal system. It is a cation. It helps with skeletal maintenance, regulates muscle contraction, especially cardiac muscle contraction and neuromuscular function. 99% is found in bones and teeth. It forms the minerals in bones and teeth. It stabilizes cell membranes. It regulates muscle contractions and relaxation. It maintains cardiac function and functions in blood clotting. It is regulated by the parathyroid hormone, the parathyroid hormone, as well as calcitonin. Some sources are dairy products and green leafy vegetables. So that is calcium. Again, functions, I just talked about this, but neuromuscular function, cardiac function, helps with blood clotting and activates specific enzymes. So it does aid in transmission of nerve impulses and contraction of muscles. The levels are controlled by vitamin D, calcitonin, and the parathyroid hormone. All right, so with hypocalcemia, this is considered less than 8.2 milligrams per deciliter. It can occur as a result of vitamin D deficiency because they kind of work together. Also hypoparathyroidism, diarrhea, malnutrition, lactation, pregnancy, chronic renal failure, bone disease, alcohol abuse. Vitamin D is required for calcium absorption from the GI tract. So if you take calcium all you want, if you don't take it with vitamin D, it is not going to work. So causes of hypocalcemia can be excessive loss with GI tract draining wounds, inadequate intake, pancreatitis. Elderly are a risk factor for this because they consume less milk. They may have less exposure to the sun, which is a source of vitamin D, which obviously it helps again to increase the GI to absorb the calcium. Some drugs that can interfere with calcium absorption are Lasix, some anticonvulsants. Alcohol can also interfere with calcium balance because it will reduce intestinal absorption because the alcohol is in the intestines. Some surgery may produce hypocalcemia within 24 to 48 hours. Decreased calcium can also be caused by decreased intake, obviously, or absorption, or increased calcium excretion. Certain eating disorders, laxative use, patients having multiple blood transfusion can all have low calcium. So some signs and symptoms, dependent of rapidity of the onset and severity. So depending on how fast that this happens, acute and moderate, we can have excitability of the nerves, which can lead to focal numbness, muscle spasms, paresthesia, twitching, tremors, and tetany. Chronic, we can have coarse hair, brittle nails, cataracts, chronic pruritus, which is itchiness and dry skin. Diagnostic tests are Trousseau and Chopsek test. So we'll talk about those in a little bit. Severe symptoms managed with IV replacement of calcium gluconate at a moderate rate. Assess for other electrolyte abnormalities such as hypomagnesia, hyperphosphatemia, and hypoalbuminemia. We will put them on seizure precautions. Um, we will want to prevent airway obstruction because laryngospasms can occur with this because of the neuromuscular issue. So the trousseau and chopstick sign. So if you put on a blood pressure cuff and you hold it on, pump it up, and you hold it up for 2 minutes, if a patient starts to their hand starts to contract inwards like this hand is, that is a sign of that they have hypocalcemia. And then chopstick sign is when you take your finger and you rub against their side of their face will twitch up like this with the stimulant. So those are two signs that you can do. So then we have hypercalcemia, which are considered levels greater than 10.2 milligrams. Causes are sometimes malignancy, primary hyperparathyroidism. Those are typically the principal causes of hypercalcemia. Medications such as thiazide, diuretics, lithium, calcium carbonate, theophylline, toxicity, and hypervitaminosis of vitamins A and D can also cause hypercalcemia. So you can have an overdose of vitamins, essentially, causing you to hold the calcium. All right, so signs and symptoms include bradycardia, hypertension, thirst, lethargy, muscle weakness, abdominal discomfort, constipation, a decrease in deep tendon reflexes. If they have acute moderate hypercalcemia levels, which are extremely high, 11.5 to 18, have anorexia, nausea, vomiting, lethargy, joint and muscle aches, and confusion. So treatment's going to depend on the severity of the hypercalcemia. We're going to typically treat the underlying cause because there's usually a cause to it. If there's a malignancy, if it's hyperparathyroidism, they may go in and do surgery. If it's renal failure, they can do that with a partial parathyroidectomy. If it is caused by hyperparathyroidism, they can discontinue the thiazide diuretics, vitamin and mineral supplements, and a low calcium diet. So here's just a way to looking at, again, to have the nursing implications and managements of hypocalcemia. And then here's some other things with hypercalcemia. All right, so magnesium. The normal serum level of magnesium is 1.6 to 2.2. It's found in the skeletal system. It is responsible for intracellular metabolism, protein synthesis, regulation of cardiac and neuromuscular function. It's important for bone health. It helps keep blood pressure normal, promotes restful sleep, good for muscle strength, needed for vitamin D assimilation. So typically you take vitamin D and magnesium together and it will help magnesium actually be just like calcium. Vitamin D will help your body be able to metabolize the magnesium. It aids with weight loss and helpful for pregnancy. Function, it's mostly in bone, 60%, regulates neuromuscular function. It can have a sedative effect, so if you have trouble sleeping, you can take magnesium. It helps with neuromuscular junction and cardiac function. It's needed for healthy bones and teeth. Also beneficial in preventing myocardial infarction, strokes, and osteoporosis. It's a very good electrolyte to have. All right, so hypomagnesia, serum level below 1.6. Can be because of malnutrition, excessive excretion of magnesium via the renal system. Hypokalemia and hypocalcemia may also be present in patients with hypomagnesia. Some signs and symptoms, primarily neuromuscular and are associated with symptoms of hyperactivity. Symptoms of low magnesium can be seen in muscular, central nervous, cardiac, and GI systems, muscle weakness, cramping, tetany, Hyperactive reflex tremors, Trousseau and Choff-Stack signs may also be seen in hypomagnesia. You're not going to see those as much as you would with the calcium, but it is possible.